without wasting much time, I first like to thank Dr. Shruti for giving me this opportunity. The talk was a little crooked, I think. So my talk today is, do novel systemic approaches reset the clock for treatment selection and sequencing in metastatic colorectal cancer? And in next 20 minutes or so, I will try to prove that it may. This is my schema of presentations. I'll be briefly discussing about the background, novel systemic therapy in the first line and subsequent line, and molecular biology and other factor determining the personalized treatment. So the advantage of personalized medicine for patients, as we know that the biomarker status of patient may help us to optimize the therapy selection, prevent adverse drug reaction, improve the quality of life, increase treatment adherence, and subsequently it can also help to manage the cost of healthcare by removing unnecessary treatment. And we also know that different characteristics influence the treatment choices in the first and later line of metastatic colorectal cancer. For an individual treatment, namely the patient characteristics like performance status, age, and comorbidities, the molecular characteristics like the RAS, RAF, MSI, or HER2, which we'll be discussing in detail. Also the tumor characteristics like tumor location, the right-sided versus left-sided, resectability and tumor burden, and last but not the least, the patient preference. And therapy should be tailored according to the individual patient need. We also know by now that colon cancer is more than a disease, one disease. So there are molecular difference of microsatellite unstable versus microsatellite stable disease, RAS wild type versus mutant disease, HER2 amplified versus non-amplified disease, and BRAF wild type versus mutant disease. Also, we know that there are anatomic difference of right-sided colon cancer versus left-sided colon cancers, and we have molecular proof for that. We also have a stool microbiota, that's flora types, which can determine the both the prognostication and prediction of the treatment response, and of course, young versus old. Now, if you look at this photo of this image, and this is the possible treatment strategy in one page. I mean, if I read this, I may not have to go anything beyond this. So we can decide our treatment way on basis of a patient which is RAS wild type versus RAS mutant, and or a BRAF wild type versus BRAF mutations, or an HER2 amplification versus non-amplified. And there are also some subgroup which has come new, like that MSI high, which can be both RAS wild type versus RAS mutants, and we have now PD-1 inhibitors with or without the anti-CTLA-4 monoclonal antibody for that, which we'll be discussing. So if you look at this NCCN guideline version 3 2021, most of the drugs you will see is a standard, that is Folfox with bevacizumab, or Capox with Bev, or Folfox with anti-EGFR monoclonal antibody for a left-sided RAS-RAF wild-type tumor. The new thing which has actually come is the deficient mismatch repair group, or the MSI high group. We now have anti-PD-1 antibody pembrolizumab along with nivolumab with or without ipilimumab. And this particular drugs has come as a first-line choice, both patients who are appropriate for intensive therapy as well as more frail patients. Now, if we look at this particular subset of MSI high and MMR deficient group, which is roughly, I would say, about 15% of our metastatic colorectal cancer population, and we have these approved checkpoint inhibitors. Now, what are the evidence for that? And now, as we know, these evidences has come in a more later part of the treatment sequence, like second, third line beyond. And on the basis of that, we have also built up cases for the first line. So let us see what are the evidence in the first line. So the first line evidence for pembrolizumab is given by a trial called Keynote 177, which is a randomized open-label phase 3 trial where the patient with treatment naive MSI high or DMMR metastatic colorectal cancer were randomized into single-agent pembrolizumab 200 milligram Q3 weekly up to 35 cycles versus investigator choice of chemotherapy. There was a dual primary endpoint of PFS and OS. The final PFS analysis did demonstrate a superiority of pembrolizumab versus chemo, and the median PFS was more than doubled at 8.2 versus 16.5 months in favor of pembro, and the p-value being 0.002. And on the further follow-up, the next years, they also presented the PFS2 data, which is post-progression and subsequent therapy progression-free survival, and it did show that pembrolizumab was statistically superior PFS, both in PFS1 and PFS2. However, the overall survival data, although it was statistically numerically superior, but did not reach the pre-specified statistical significance. So it was a non-statistically significant reduction in mortality, the hazard ratio being 0.74. The reason which cited by the author is most probably there is a high crossover rate of 60% from chemo to anti-PD-1, PD-L1 therapy in the second line. However, notwithstanding the fact that overall survival did not reach the statistical significance, we now have seen there's a good response, and this drug has come in the first line in this particular subgroup. There is also an ongoing phase 3 trial including atezolizumab with or without bevacizumab, the COMET trial. There was a third arm of chemotherapy with bev, which has now been stopped after this keynote trial publication. And we also have an adjuvant atezolizumab with or without FOLFOX with or without atezo in stage 3 mismatch repair deficient colorectal cancer. So we are looking at these trials with interest, and it may show some more data how anti-PD-1 antibodies will stand in this particular section. What about BRAF mutation? Now, we know that BRAF mutations confers with a poor prognosis, and it is a RAS-RAF MAP kinase pathway. It's a downstream signaling pathway. And a BRAF mutation makes anti-EGFR monoclonal antibody treatment infructuous. And we also know that both FDA and EMA has approved that encorafenib, which is a small molecule BRAF inhibitor, along with cetuximab for the treatment with BRAF V600E mutated metastatic colorectal cancer in a second or third line therapy. I will be right now discussing the first line treatment of this particular combination in a BRAF mutated metastatic colorectal cancer. And the trial data it's an anchor trial. It's a two-stage phase 2 trial, of which the phase 1 or stage 1, which has got 40 patients, the data has come. So they have used that encorafenib with a MEK inhibitor, binimetinib and cetuximab, and there is about 50% overall objective response. And there is also an improvement in the median PFS is about 5.8 months, and median OS is about 17.2 months. So on this, there is a phase 3 breakwater study. I am really obliged to peerview.com for this slide, which I borrowed from them. So this breakwater study is a phase 3 study where there is a 3-arm of encorafenib with cetuximab, and there is an arm B with encorafenib cetuximab with FOLFIRI or FOLFOX, and there is a control arm of encorafenib cetuximab with or without bevacizumab. No discussion on molecular biology of colorectal cancer can be completed without talking about the consensus molecular subgroup of CMS. Now we know from the PETAC study there are 4 CMS subgroups. The CMS1 is hypermutated with microsatellite, high microsatellite instability, strong immune activation, and they're mostly in right-sided lesion, compared to CMS2, which is a more Wnt and MYC signaling activation, chromosomally unstable, and mostly left-sided tumor. But what is the treatment-related outcome of this? Now, from CalGB as well as FIRE3, we know that the CMS are highly prognostic for overall survival and PFS. In the CMS1 cohort, bevacizumab most probably had a better and longer OS than treated with cetuximab. And in the CMS2 cohort, patient treated with cetuximab have a significant longer OS. Now, coming to the second and third line treatment option as far as the novel therapy is concerned, again, if you look at these image of NCCN guideline, you will see what are the changes which has come. So I can, the important changes which come is again in all the stages, second line or beyond, that for a deficient MMR or MSI high disease, pembrolizumab single agent or nivolumab with or without ipilimumab has come. Also, the TAS-102 and bevacizumab is another trial, and of course the trastuzumab deruxtecan or trastuzumab with pertuzumab and lapatinib. So I'll be briefly discussing all these three and putting our case for their use. So the evidence for pembrolizumab monotherapy in patients who have an advanced MSI high colorectal cancer come from a Keynote 164, which is a phase 2 study, and where a locally advanced unresectable MSI high colorectal cancers were treated with 123 patients with the two cohorts of cohort A, which has 2 or more prior lines of therapy, versus cohort B, which has less than 2 lines of therapy. And the primary endpoints was objective response rate, and secondary endpoint was PFS, OS, and duration of response. And if you can see that in both cohort A and cohort B, there was the overall response rate was quite high. The cohort A has a 3-year overall response rate of 49%, and cohort B has a 3-year overall response rate of 52%. So if you consider them that the patient has already received maybe 2 or 3 more than 2 lines of therapy, these results are actually quite interesting. Now, we also have seen that people have tried to use anti-PD-1 monoclonal antibody with anti-CTLA-4 monoclonal antibody. So Checkmate 142 is one trial where they use nivo with ipilimumab in MSI high metastatic colorectal cancer. The primary endpoint was overall response rate, and the secondary endpoint was ORR by the independent reviewers, and there was also exploratory endpoints of safety, tolerability, PFS, OS, and biomarkers. So if you look at this graph, you can see that the PFS of the combination was superior than the single agent. So nivo plus EP is has shown a better PFS than the single agent nivolumab. In the year 2021 August, also there's new drug, another PD-1 anti-PD-1 monoclonal antibody, dostarlimab, been approved by FDA for any DMMR MSI high colorectal cancer, or for that matter any solid tumor. This is a tissue agnostic drug. It was started with endometrial cancer, but in non-endometrial cancer also it is shown. So, so along with maybe NTRK inhibitors, this is again shown that we might be looking for some tissue agnostic treatment options. I'm again obliged to peerview.com for this particular slide, which I borrowed from them. For a BRAF V600E mutated patient, the data of superiority of anti-BRAF small molecule inhibitor encorafenib has come from Beacon study, which is a phase 3 study. It has got 3 subgroup. One has got cetuximab with encorafenib with binimetinib, which is an anti-MEK inhibitor, cetuximab with encorafenib versus investigator choice of chemotherapy. Both triplet versus chemo control, the non-chemo arm showed superiority, and that by quite wide margin. However, once we checked the triplet of encorafenib, binimetinib, and cetuximab versus the doublet of encorafenib and cetuximab, there was no statistical difference. So the EMA has actually approved the doublet of cetuximab with encorafenib in this BRAF V600E mutated patient in second line and beyond. Coming to HER2 biomarkers for metastatic colorectal cancer, so there is a small subset of patients, maybe 2 to 4%, which has got HER2 amplifications, and they are not overlapping with that RAS-RAF mutations. And Destiny CRC1 has shown that trastuzumab deruxtecan patient drug can shows a good response in the HER2 expression metastatic colorectal cancer. So This is Destiny CRC1, and it has shown that about a 45% of overall response rate by independent clinical review. And there was also a 6 months PFS of about 53% of HER2 positive patients. So there was also non-HER2 positive patient, which obviously didn't show any benefit. So trastuzumab deruxtecan is seriously being considered as an important treatment option for this small subsets of patients.
So 2 minutes left, sir.
Okay. I believe there are 15, 16 minutes. I was giving 20 minutes, ma'am.
Okay, sir. We'll be having time for
my clock is on, ma'am. It's showing 15:52. Anyway, so we also have a Heracles trial which shows dual HER2 blockade, and my pathway which shows trastuzumab and pertuzumab and showing some good response. There was also adagrasib, which is a KRAS mutated G12C mutations pathway. This drug has shown some interesting data, which has been shown in the Crystal-1 study. And people have also tried regorafenib along with nivolumab. So there is some study from the phase 2 data. And also in patient who has beta MSS, a PMMR patient, people have tried PD-1 antibody along with tyrosine kinase inhibitor. There is a data from pembrolizumab with lenvatinib. So if you look at these preferred choices in second line treatment, we can roughly say that if you have all wild type, you can use doublet with EGFR antibody or bevacizumab, depending on whatever you have used, and the chemotherapy depending on whichever you use in the front. If you have a RAS mutated patients, you can use FOLFOX or FOLFIRI with bevacizumab or aflibercept or ramucirumab. For an MSI high patient, you have pembro with nivo, and BRAF V600 mutation, you have cetuximab with encorafenib. For a HER2 amplified second line or greater line, you can have a combination of anti-HER2. For a frail patients, if they are MSI high, pembrolizumab remains a choice. So now along with RAS mutation, MSI status has become imperative in all colorectal cancer metastatic patients. So I cannot overemphasize that when you are doing, please do MSI along with it. So I will not be discussing this. So we also know that we have already discussed the left-sided versus A, the CMS1 and CMS2, and treatment options. And left-sided tumors have a better prognosis than right-sided tumors, and they improve. Left-sided tumors get better response for anti-angioma monoclonal antibodies. So we must discuss this molecular testing with patients and the benefits of testing, how test results can affect the treatment. There is other implications for family members. And so this patient is also indicated. So this study, they have shown that this discussion with molecular testing and patient can really convince them. So if we, again, this what Dr. Van Kastem has very nicely shown. So if you have a right-sided MSI high metastatic colorectal cancer, there may be a pembro and or nivo with EP may become a treatment of choice. For a BRAF V600 mutation, encorafenib with cetuximab maybe become a first line. If on a second line, if the tumor has progressed, we can use FOLFIRI plus BEV. Or if you have not used the MSI, the PD-1 or BRAF inhibitors, you can use them in the second line or third line. So I would like to summarize that molecular profile of tumor is gradually becoming an integral part in the optimum management of metastatic colorectal cancer. And although chemotherapy and biologic targeted agents are still mainstay of treatment, novel therapy is gradually bringing a paradigm shift in a way metastatic colorectal cancer is presently treated. MSI high patient, they do respond to anti-PD-1 monoclonal antibody, and soon it may become a part of treatment choice. And the RAS-RAF mutated patient with doublet combination of encorafenib and cetuximab have shown promising result. For HER2 amplified tumor who are RAS-RAF wild type, anti-HER2 monoclonal antibody including trastuzumab deruxtecan or a doublet of trastuzumab with pertuzumab or lapatinib is an effective option. And last but not the least, I think combination of various factors like molecular profile, tumor characteristics, patient characteristic, and patient preference and logistics, please don't forget that, in a resource country like ours, will be key in future decision making for treatment. Thank you.
Thank you, Dipanjan. It was wonderful to see you whiz through everything over such a short time. And I must congratulate the ISMPO team for such an amazing program. So I just have, we were at the molecular MDT yesterday as well. And
Yes.
every week we talk about this in colorectal. So apart from RAS, BRAF, MSI, HER2, is there anything else that actually guides your decision making in the clinic today?
Ma'am, are you asking me the molecular?
Yeah, I mean, we talk about these big NGS panels, 500 genes, 700 gene, DNA, RNA. But the bottom line is, does anything else other than these four drive your decision making for the patient sitting in front of you in the clinic?
So if you are looking at the actionable mutations, these are the most important actionable mutations at present we have. And of course, these KRAS mutations and those is upcoming. In very practical sense, the most important thing with guide my treatment decisions in patient in my clinic is a combination of 4-5 things. One is, of course, as I discussed, the patient characteristics, the tumor characteristics, and the patient wishes, and the logistics. So I personally think that doing a 500 gene panel may not give us any immediate treatment related benefit. It may have an academic interest, but as long as we have an actionable mutation, which a drug which is available, widely available, and affordable, will not change. So I think for the next few years, the standard chemotherapy with monoclonal antibody will remain per se. But gradually, I believe, in lung, we are looking at a molecular-driven treatment paradigm shift, which will be in the first line, second line, and third line most probably will be decided almost in the beginning. But as of now, no. Beyond these 4 or 5 things, I'm not looking at anything else.
I think that's an excellent summary. Any other questions? Otherwise, I think we'll close the session. I'm filling in for Dr. Ankur Bhel.
My pleasure seeing you, ma'am.
Yeah.
Yesterday, I could not talk much. I was at, but I must congratulate you on this forum, on this. If people doesn't know, Dr. Sirohi runs a great molecular MDT, and I request everybody to be part of that. That's really, really insightful.
Thank you, Dipanjan. And lovely to see you, Dr. Sanjay. I'm seeing you here after a long time. Thank you, Rekha. Over to you.
Yeah. So, Dr. Deepak, any comment from your side?
Dipanjan, I think this was one of the very, very well summarized talk, at least for a surgeon and from a surgical perspective. The only question that always keeps on debating in a surgeon's mind as to where all is your treatment leading to. Can we surgeons try and help you out here? Number one. And the question is, when we are looking at all of these treatment options, incorporating the entire next genome sequencing and all those 500 panels and all that, are we looking at some kind of a surgical therapy at the end of it? What are the conversions of a metastatic disease? Colorectals, we've always been striving hard to make it a liver-limited or organ related disease, even if it comes to a peritoneal carcinomatosis today. Where are we today, and where do you predict the future? This could be taken by Dr. Bhavna as well. Where do we look at it from here?
So I think, Dipanjan, you made a button as well. I think like we are aiming for, there are certain prognostic scores like I do in my clinic where we look at the CA and a lot of other markers as well. And we had a patient who came 2 years later with a PCI of 3 in liver-limited disease. So this patient had undergone HIPEC and, liver resection. So I think what we are trying to do is not write off all stage 4 patients. We are trying to see what we can do to prolong not only their disease-free survival, but hoping that, it will prolong overall survival. I mean, doing randomized trials in these niche population is very difficult. I understand that. But I think the evidence is coming up that, patients with low PCI and liver limited disease, or those who have liver limited disease, I think the patient's biology decides everything, the disease free interval, especially if they've had a 6-month disease free interval or longer. I would actually, a year later, a lot of times I have revisited my decisions, where we've said, only palliative chemo, we've revisited it after 1.5, 2 years in quite a few patients. Would you agree, Dipanjan?
Yes, ma'am. I think that reminds me a small poem. If you were at Waterloo, makes no difference what you do if you were at Waterloo. So Dr. Deepak, actually with these markers, we are not only looking at the predictive markers as treatment, we are also looking at the prognostic markers. So we are trying to understand which disease will behave well and which will not. In fact, the whole purpose, and surgery still remain even in stage 4 in colon cancer, particularly one of the most important treatment. In fact, if you look at TRIBE study, we are trying triplet with chemotherapy so that things may become resectable. However, having said that, once I think everybody would like to know which tumor will behave well so that we can go for more aggressive therapy, including surgery, which is and will remain an integral part. So I think that one of the important thing what molecular scoring or molecular markers will ultimately lead to is to decide that on which patients we will select for more aggressive therapy in all stages on lines, and which on patients which will not go for very aggressive therapy. I think that is one of the most important things, but molecular marker, in my opinion.
Sanjay Sharma had put on his hand. He wanted to probably comment on something.
No, as Dr. and Bhavna well summed up, the only problem that we in India, for some reason, the surgeons are not yet geared up to consider that the liver limited and the other diseases, you need to tackle the metastatic disease first rather than primary. And probably there is a delay in handling these cases. So the primarily what Dipanjan mentioned about those markers are really saving a lot of life now, and I'm sure we're looking for further markers to look into it to save more patients. But we are now at least about, in my practice, I'm able to save at least 50% of the patients that they come to me with liver and lung limited disease, and we are saving them, and they have a reasonably longer survival. So that's my saying, that instead of rushing for a primary surgery straight away, unless and until there is a medical exigency, I think we should handle the metastatic disease first.